actually the incidence of diabetes and other lifestyle diseases is increases day by day. Simultaneously, we intervention cardiologists are getting a lot of complex coronary interventions in our day-to-day life. If you talk about the bifurcations, we often see the bifurcation lesions in day-to-day our interventional practice. If you ask about the data, I would answer this question is like we see around 15% to 20% cases which are actually bifurcation lesions. It includes LAD D1 bifurcations and LCX-OM bifurcations and LMCA bifurcations as well. See, it depends on the various anatomical features like Medina classification. If the side branch is having osteal disease, then again the side branch protection is very much important. If you ask me that what is the cases in which we need the side branch protection, among 15 to 20% cases, most of the cases we do with the provisional stenting, but around 5 to 10% of cases in which the side branch is involved, the ostia is significantly diseased, so we need to have the side branch protection. So it comprises around the 5 to 10% cases. So if you ask about the dedicated bifurcation stenting, there are a lot of techniques described to do the dedicated bifurcation stenting. So commonly we used decay crush or mini crush or culot in our cases in dedicated bifurcation stenting. But the data says that the most effective way to do the dedicated bifurcation stenting is the decay crush technique. Most of the time we finish with the provisional stenting, but in case if we find that the side branch is compromised after the provisional stenting, we may use a tap technique or reverse decay crush technique in certain cases as well. See, when you treat the bifurcation lesion, the side branch ostia is the very nasty one that comes with the re-stenosis in the future. So we have to basically give focus to the ostia of the side branch, because ostia of the side branch is mainly fibrotic. The chances of developing re-stenosis or acute events are very much common in the side branch. So we have to treat the side branch very aggressively so that we can have a procedural success. The stent recoil is depend upon the native vessels fibrosis. As I mentioned earlier that the side branch ostia is very notorious and it is mainly fibrotic or fibrocalcific lesion. So sometimes or many a times imaging can help us to characterize the lesion, to choose the plaque modification strategy, and mostly in my cases I do the scoring balloon or cutting balloon, sometimes rota or orbital atherectomy to expand the lesion or bed preparation. So a good bed preparation leads to the less recoil, but if you are not preparing your bed good, then the chances of stent recoil and missing the geography miss of the geographical carina is very much common. But in these kind of things you have to take help of the proper imaging, proper fluoroscopy and optimal good bed preparation. It is very important that the selection of a stent you are choosing in the bifurcation strategy, because if you see the anatomy, side branch sometimes emerges in a very acute angle or extremely wide angle, and after that the vessel might be a tortuous one. So in that subset of cases, tracking is a very much problem, especially in the left main bifurcation lesions. And in certain scenario in which your provisional stenting converted into the bifurcation stenting, then passing a stent through a main vessel of the stented main vessel is again a very big problem. So in these subset, you have to choose a very good trackable stent, very good stent that is being a very good radial stent. It is very important, because many a times we face a problem of the tracking of the stent into the tortuous vessel or calcified vessel during the bifurcation lesion. Optimal side branch expansions, actually it is very important step during the bifurcation strategy. Again, I would say that the good post dilation is the important part of the long-term outcome in the bifurcation lesions. So we have to choose that stent in which we have a good expansion data of the side branch, because if you see the coronary anatomy, it is tapering. So we have to dilate the ostial part much aggressive or more as compared with the distal part. So side branch expansion is very much important part of the bifurcation strategy as well as the long-term outcome of the procedure. Dedicated bifurcation stents are being manufactured by some companies in the India, and we are using these kind of the stents very often in our interventional practice. They have certain good features in terms of the easeability of the procedures, but there are certain limitations as well. So there are mixed kind of comments. I would say that it is being pretty easy to use, but simultaneously the expansion is again a bit challenge in dedicated bifurcation stents. Side branch, again a side branch success is very important for the outcome of the bifurcation strategy. We generally measure the side branch flow with the various techniques. First and foremost one is the fluoroscopically we can assess the plaque burden or the modification of plaque after placing the main vessel stent. Again, we can use the any imaging like OCT and the IVUS to measure the optimal MSA to the side branch stent. Again, we can measure we can generally see the TIMI3 flow for the success of the side branch stenting. And again, in the long term, I would recommend that everybody should have angiographical follow-up either by the CT, either by the angiography to see the result after the complex dedicated bifurcation stenting. So the long-term follow-up as well as the clinical symptoms, again it is a marker of the success of the side branch stenting, and obviously we can see the various features like plaque shift, TIMI3 flow and the IVUS guidance as well. If you ask about the optimal side branch expansion, I would say it is the most important part of the bifurcation stenting, because we all know that if you follow these kind of the patient in terms of the re-stenosis, the most common spot, or you can say most common area of the re-stenosis is the ostial side branch position. Because it is a fibrotic position, it is a very much fibrosis takes place in the ostia. So we need to have a good bed preparation with the various plaque modification device that leads to the proper expansion, and again it leads to the long-term outcome of the patient. So it is very important. So see, if you go through the various guidelines of the bifurcation, it is mentioned everywhere that the provisional stenting is best strategy for most of the cases, especially if you have a non-significant side branch plaquing. So we have to choose such a stent in which we can be very sure that it is not going to shift the plaque in the side branch during the POT or during the post dilatation. So there are certain stent designing by the various company. They are dedicated to it that they can preserve the side branch flow, they can protect the plaque shifting from the side branch, and they have a larger stent struts, and again less crown and more spaces in when the stent placed in front of the side branch. So definitely I would recommend such kind of the stents, which are basically designed for the bifurcation stenting, and they ensure that if we place these kind of the stent, there are less plaque shaped, and they achieve good end results with the less side branch compromise. See, we are basically we are a part of various trials running in the India of the bifurcation lesions. So over the period of time, we learn various things regarding the bifurcations. So I would find that it is very important to work on the stents to save the side branch, to protect the side branch, to various stent design that the companies are working, and I would strongly in the favor that we should develop such kind of the stent design in which the side branch should not compromise during the bifurcation stenting.